comes. So, good afternoon, gentlemen. I'm going to take you through the started 8 minutes of post-refractive IL power calculation. And this is alternatively can be called an biometry from hell. And to guide you through this graveyard of ophthalmic reputations is going to be your friendly neighborhood ophthalmologist here, roasting in Delhi's heat. Very well. So why is it such a problem? There are basically three problems. And the first is instrument error. The second is the keratometric index error. And the third is the formula error. Let's take them one by one. I will go slightly faster so that my other speakers can have some time. The instrument error is the first is the keratometer. Remember, it measures the radius of curvature of the paracentral cornea, not the central cornea. So this misses the central flatter zone after myopic LASIK and overestimates the corneal power by a mind-boggling 15%. So that is a huge amount, just because it is just measured the paracentral and not the central. It is blind to the center. The second problem is an index error, which is due to an assumption which was made in the infancy of keratometry. The normal refractive index of the cornea is 1.376, is not? But the assumption states that it is actually 1.3375. Now, why is this? This is because if we take this assumption, then it converts a 7.5 millimeter radius of curvature of cornea into a nice round figure of 45 diopters keratometry. That is why it was taken. But remember, this assumption is only true for a virginal cornea. It is only true for a virginal cornea when the corneal back to front surface radius of curvature ratio is 82%, which is normal. This is not true in myopic LASIK, where it changes to 68%. And after hyperopic LASIK, it changes to 90%. So this assumption is completely false and adds another 10% of error, so which means a total of 25% error of keratometry. Now, that's a huge amount for calculating IL power. So what do we do? So what we do is to directly measure the central corneal curvature, anterior and posterior, with the help of instruments which you have now, the PENTACAM or OBSCAN 2 or the OCT, whatever you have. We have the PENTACAM, which is now very common. And we use this PENTACAM, use a rotating camera with an unpronounceable name, which captures 25,000 data points in 2 seconds. And creates a 3D image of the anterior segment of the eye like that. So this gives us, so which image should we pick up from the PENTACAM? Out of the mind-boggling number of maps that the PENTACAM has, we pick up the holiday report. Holiday report, as you can see there. The holiday report, which measures corneal power at different zones. It was done in collaboration with Dr. Jack Holiday and Oculus. And we take the EKR map, the equivalent K-reading map, which measures central corneal powers across various diameters. You can choose your diameter. The best diameter, in my opinion, though it varies, is about 4.5 millimeter for central corneal curvature. Why? Because less than 4.5 excludes too much of the pupil. More than that, the Stiles-Crawford effect kicks in, which means that the intensity of light decreases when the light enters the pupil from the edge and not from the center. So you take the 4.5 map, we pick up the keratometer, and we have got our keratometry correct reading. What about the third problem, which we seem to have forgotten? The third problem involves the ELP, effective lens position, which is the post-op IOL position, which is the holy grail of biometry, which is the most critical feature for all formulas and it's difficult to estimate. Now, the third generation, so-called American formulae, Hoffer-Q, Holiday 1, SRKT, etc., the ELP is predicted by the axial length and the keratometry. But as we know, keratometry is going to be flat here, is not. So the flatter K assumes a shallow anterior chamber and estimates the ELP more anteriorly. But this is incorrect. There's no change in ELP at all because the anterior chamber is just as deep as before. It's only that the cornea has become flatter due to refractive surgery. So it's a completely false thing, and this is an additional error. So we can correct this by the Arambere's double K method, a landmark paper, where we use 2 keratometries. One is the pre-refractive surgery keratometry, which predicts the ELP, so that's fine. And second is the post-refractive surgery keratometry, which predicts the IL power calculation. And this correction has to be applied in all third generation formula, otherwise in deep trouble, like in this example. Let's take a preoperative keratometry of 45 and post-refractive keratometry of 36. Axial length is 24.5. A constant is 118.9. Let's say I want to put an IOL of that constant. Calculating for emetropia using the holiday one, but no double K correction, I get a 26.6. But if I use a double K, I get a 29.37, which is a 2.8 diopter hypermetropia, which means on day one, patient can barely see the 660 line. Okay, so that's in deep trouble. So we have to include this correction in all the formula. Now, one trivial question. How many formula have been published for calculating IOL powers after refractive surgery? It's a mind-boggling 35, and still more coming and counting, is it not? So which one do we choose? Decisions. Let's make it easier for all of us. We have these free online IOL calculators. Many of them, the most popular is the one published by the American Society of Cataract Refractive Surgeons. But we also have the iLab and we have the APCRS also. The most popular and the simplest, I think, is the American Cataract Surgery. So we go to this website and we find the calculator like this, and we feed in all the data. Pre-refractive, which gives you the refraction, the keratometry, and post-refractive refraction, and the keratometry and the topography. We feed in all the details. It's pretty simple once you've got all your findings. And then we press calculate. The most beautiful word in the English language is not I love you or check enclosed, but calculate. You press calculate, and here you have. Let's take an example of how much maths is taken care of by the online calculator. Look at the maths. This is an example of a pre-LASIK refraction of minus 11.25 and a post-LASIK refraction of a minus 2.25. That's quite a bit. Pre-LASIK keratometry was 42, post-LASIK is 36. Axial length is 20H, which does not change. AC depth is 3.5 millimeters. Now, this is what we have data. But remember, this is the refraction, but this is not at the cornea level. At the cornea, which is calculated by the online calculators, the refractive power at the corneal level is completely different. And this is taken care of through the maths. The pre-LASIK refraction is actually using complicated formula at the cornea is not 11.25, but minus 9.91. Similarly, the post-LASIK diffraction at cornea is not minus 2.25, but minus 2.91. So the actual correction at the cornea is actually 7.72. So the corrected K comes out to be 42 minus 7.72, which is 34.28 and not 36 at all. When we apply this to the formulas, let's look what we get. We get a 20.6 to IOL power calculated by the clinical history method and the double K, 20.4 by Shamas, 20.8 by Haggis, 20.6 by the Masket and the SRK. The consensus is 20.62. Being generous, we implant 21. And we have a marvelous post-op refraction of minus 0.5 cylinder of 90 degrees. Absolutely astonishing. A patient crying with happiness and a doctor laughing all the way to the bank. Very well. Now, about RK is a completely different ballgame altogether. In RK, the problem is that the both surfaces flatten actually, as you can see here, but not equally. And the sheen fluke images reveal to us the posterior surface flattens more, 33% compared to the anterior surface, which is 22%. And coupled with the smaller optical zone, the instrument error is more likely. So again, we go back to direct estimation by the central formula made by PENTACAM. Let's see how surgeons have learned over the many years. Look at this problem we had. A 43-year-old male with a cut left eye, RK done 17 years ago for minus 11, 8 cuts RK, a pre-op refraction before cataract with 2.5 with a minus 4 cylinder, leading to 6.8. This is for cataract, before cataract. K1 52, K2 38.5, and axial length is 30.5. IOL power calculated for emetropia with SRK was 1.5. A very nervous and palpitating surgeon implanted 5 diopters to be on the safe side and lands up with a post-op refraction 4 weeks later with a mind-boggling plus 12 diopter with a minus 2 cylinder. And this is the surgeon's condition trying to dodge the patient. I beg your pardon, I don't know if it's going to work. This is the condition of the surgeon now who's trying to dodge the patient all over. I'm sure we don't want to get in this condition. So this is what happens if you go by your instinct. So what we do is go back to again the IS calculator, ASCRS calculator, our old friend, feed in the details, press calculate, and get the answer. So what are the take-home points? We have to educate the patient about IL power estimation and not a calculation. Aim for myopia about -1 for RK. IL powers multiple formulae because no single formula is superior. And when in doubt, choose the higher IL power. Avoid multifocal IOLs like you would avoid your ex-girlfriend. Thank you very much, ladies and gentlemen, for having the patience to listen to this rambling talk. Thank you very much.